Our greatest strength as physicians is our professionalism of our staff, our physicians, ancillary services, but it's also one of our greatest weaknesses. Often we're working in an autonomous manner, and this gives us independent care plans, which basically turn into what I call the 4 C's of inefficient healthcare delivery. And that's confusion, complexity, inconsistency, and costliness. When we have multiple different care plans, it creates an inefficient system. It also creates complexity for the patients, as they have many different places that they have to be treated, and the inconsistency comes from different questions. And we're asking questions of the same people, and we're getting multiple different answers. And the costliness comes from duplication of services. So the number of joint replacement surgeries is growing at an extraordinary rate in our country, and it puts extreme pressure on already rising costs of healthcare. The National Center for Healthcare Statistics has estimated that there's 45 million people in the United States that have arthritis pain. And that equates to about 1 in 5 adults. We have earlier onset of arthritis because of the rising obesity problem in our population. And we have an aging baby boomer society. This increases the volume of hip and knee replacements. Talk about baby boomers. 78 million people.
Doctor,
Yeah.
could you speak up
No.
a tad?
No.
Thank you. Thank you.
We have about.
I have hearing loss.
No. You have hearing loss, or
I'm
you have
just
to
kidding.
come sit in the front row?
Yeah, I'm just kidding.
All right. The total number of. Did you forget one of my slides?
No. Did you skip it on it?
No, that's all right. Aging baby boomer society. We have estimated that there's 78 million baby boomers, and a significant number of them are just turning 65. And these are people who are not in the traditional mold of what we call the graying society. 65-year-old people these days are much more active, and you can see the increase in the health spa memberships of people that are over the age of 55 has increased 350% over the last 10 years. So we have an aging society that's trying to stay young. They're being more active, and also with being more active and more internet savvy. There's people that are getting on the internet. They're trying to find access to the better hospitals and better physicians, and they're also willing to travel to those places where they feel like they're going to get better service. There's a Harvard PhD who wrote a classic book on medical economics, and basically one of the things she described in this book was that we can find out more about the car we're about to drive than we can about the physician that's about to perform our surgery on the internet, and she thinks that that's a significant problem. There's a term that's being used for these aging baby boomers, and it's called nosumers. Not consumers, but nosumers, K-N-O-W, because these are people that want an understanding and knowledge of the health care that they're about to purchase. So along with this increasing, just to go over the numbers of the increasing total joints, in that primary total hip arthroplasties, there's 350,000 done in 2009, and that's a 50% increase since 2000, and 500,000 total knee arthroplasties, which is a 65% increase. This does not include the revision procedures that we perform for the joints that have been wearing out over 15 to 20 years of normal wear and tear. Now, the CMS data on the revenue for total joints replacements, basically $2 million is spent on hips per year and $2.4 billion is spent on knees per year. We can also see that over a period of time, that there's going to be a significant increase in the total hips and total knees done. If we look at the data over the next 5 years, we expect that the total knee replacements will increase from 350,000 the total hips will increase from 350,000 to 600,000 per year, and that we'll be doing almost 1.5 million total knees per year by the year 2015. So basically what we're having is a significant increase in the number of joint replacements that are being done, as well as the costs which are rising. we say that Medicare is responsible for about 55 to 60% of the payments. I mean, total insurance payments for hip and knee surgery in 2005 was $24 billion. It's a significant amount of money. Hospital reimbursement for that period of time was about $7 billion. Their actual costs were $9 million. So the hospitals are basically being reimbursed at 80% of their cost. So it's not something that hospitals are really looking towards significantly increasing. However, we're stuck in a situation where we're caught between a rising number of people that are requiring this and a government that's pursuing a reform in the way they're paying for these services. So this is just kind of a busy slide that shows you Medicare pays for a lot of different things, but then the problem that we're coming into is the Patient Protection and Affordability Care Act, which was passed in 2010, which includes $425 billion of reduction in Medicare spending over the next 10 years. So we have to find a way to provide these services to more people at a lower price. And really, what I just talked about there, none of that really accounts for the increasing costs of the technology that we demand and that we ask for our patients. So this has resulted in fundamental changes in relationships between the physicians and the insurers. There's a growing initiative for outcome-based treatments and the prevention of avoidable errors. So we must transform. We have to reevaluate our present system of delivery into a more patient-centered experience for the patient. It has to be patient and family-oriented. We must provide excellent service, quality care. It must be more cost-effective. Recently, Trinity Hospital has had the designation of the Blue Distinction designation in hip and knee replacement. And what this is an evidence-based objective criterion based on length of stays, number of procedures, skip recommendations, and various other parameters which have been established by expert physicians and professional organization recommendations. And the goal of this is to identify the best practices in specialty care and which are delivered on a consistent basis, and it also allows physicians to improve the overall quality and delivery of their care. This is really the first and most important step in transforming from the traditional autonomous delivery care to a more patient-centered model. One major flaw in our current system is the lack of coordinated patient-centered care. Traditionally, we worked independently towards our own goals. Basically, we work in silos, and that was explained to me by a physician who really kind of designed a lot of these programs. He said, we're all working, trying to provide the best patient care that we can provide, but we're not coordinating our care with the other physicians, with other specialists, with the nursing facility, with the nursing staff, with the even with the people that we deal with on a daily basis in dietary and physical therapy. All of these things need to be coordinated. Basically, what we've got is individual patients who think they're providing excellent care, but really what they're doing is they're creating multiple care plans, fragmented care, and duplication of services. When we talk about transforming an industry, if we look at Henry Ford transformed the automobile industry, and he didn't do it by improving individual performances. He developed a reliable, focused, and repeatable system. But we as professionals have often resisted standardization. No doctor wants to be told how to do it, what to do, because we all think that we're doing it the best way possible. And we view it as an encroachment on our independence and our professionalism, but we need to transform our industry. In order to do that, we need to identify what's called a destination center of superior performance. And in order to provide that, we have to provide transparency of our outcomes. We have to be able to go out in the community, tell people, tell physicians, tell insurers that this is what we're doing, and these are our numbers, and this is how we're doing it. And those are the numbers that are going to speak for themselves. You go around and you talk to people, they'll tell you, oh, well, our satisfaction rates are 95 or 100%, and they don't have any data to support that, and it's just on anecdotal data. And if you really look at their true numbers, then they're certainly a lot less than that. So we have to have access to the data, and then we have to demonstrate measurable excellence. talk about measurable excellence, we have to be able to quantify the excellent experience of our patients. We have to be able to ask our patients how we're doing, did we meet our goals, have you been satisfied, and what can we do to improve it? And those are the ways we can demonstrate excellence and do it on a consistent basis. And this is the kind of destination that we're creating here at Trinity Medical Center, the total joint replacement. So improving the patient experience is one of the primary goals of what we're trying to accomplish here. We want to combine the best of traditional care and management of the patient with excellent outcomes. We have to be able to quantify this with accurate data through our HCA HPS scores, which is basically a survey which is required. It is required, right? It's required that these that these questionnaires be filled out, and it gives us some data that we can look at as to how we're doing as a hospital. The thing the shortcoming on this questionnaire is that it never asks the patients how they're doing. It only asks what did the hospital do. So it never really asks for what the patient's experience is. So in order to have a great experience by the patient and family, we have to have coordinated efforts of the doctor and the hospital to create a system that's patient-oriented and cost-effective. This basically what we're trying to do is promote a professional team and not a team of professionals. If we look at joint replacement surgery, it's ideally amenable to the service line, to a service line production, and that's really what we're talking about. Is we want to standardize care plan for patients. We want to have one certain way where we can treat them. So it's not duplication of services, multiple different orders from physicians, a nursing staff that you might get an orthopedic nurse one time, or you might get a urology nurse another time, or a cardiologist. We want to have a dedicated unit with dedicated specialized nurses, physicians who are used to doing things in a certain way. So everybody basically gets the same kind of care. The other things that make it very amenable to the service line production is that it's a completely elective procedure. We have patients come into our office, and then we decide a time in the future when we can do their hip or knee replacement. And this allows adequate preoperative evaluation of the patient. It also allows for patient education to understand the disease process of arthritis and the procedure that they're about to undergo. Familiarity with the process. We actually have them go up and meet the nursing staff and the nursing coordinators, and they understand the goals of their therapy, and they understand the goals before and after, where they're supposed to be, on what day, and the things that is expected of them. We familiarize them with the physical plan. They get to come to the hospital, see where to park, where to come into the hospital, where admission is, where the discharge is, where the cafeteria is. All of these things can decrease patients' anxieties and also improve what they see as their experience with the hospital. We can also go over the discharge process and the final follow-up. So basically, we have an A to Z process where patients are, you know where you're going and what you're doing the whole time you're in the hospital. And if we can effectively reproduce that plan, then we think we can have a great chance of getting a better experience in the hospital. So by standardizing the preoperative evaluation, we can improve patient experience, something that I call the FUD factor, is fear, uncertainty, and doubt. We have lessened anxiety with familiarity of where to park and where to sign in, a clearer understanding of the expectations and the goals of the surgery, and by doing that we have better communication between the physicians, the staff, the nursing staff, and physical therapy. And we must be consistent on our care plan. We have to personalize our hospital experience by having a preoperative evaluation by the same nurse that does your postoperative evaluation. So patients have a contact person. They're not getting multiple answers to the same questions that they're asking. One person provides more consistency, and that also can lead to an improvement in the patient's experience. And again, I talked about measurable excellence. And this is data that we have to cull from patients, and that's patient experience. We have to be able to ask the question of our patients of how